Hi, welcome everyone. It's great to see you all here. Thank you so much for joining us. My name is Caroline Kuo, and I serve as the Assistant Dean for Diversity and Inclusion at the School of Public Health. And today marks, very sadly, the last of a four-part series sponsored by the School of Public Health, along with our amazing partners, the Center for the Study for Race and Ethnicity in America. We'd like to begin by thanking the leadership at the school, at the center, and also at the respective offices that have sponsored this series. And that includes the Office of the President, the Warren Alpert Medical School's Office of Diversity and Multicultural Affairs, and also the Office of Institutional Equity and Diversity. Dean Bess Marcus has also enthusiastically supported this health equity series, and it's been an incredible opportunity to bring together leaders from all across the country, who we'll hear from today, to really grapple with some of the most challenging issues around health equity, and also to catalyze conversation within our school, within our community, about what we can do to achieve health equity in the populations that need it most. And in this particular partnership, I feel very fortunate to have partnered with the center's leadership. So standing next to me, the co-director of the Center for the Study for Race and Ethnicity, Stephanie LaRue, her amazing team, Christina Downs and Caitlin Scott in the back, I can see them. And I'd also like to thank our team here at the School of Public Health, in particular, Karen Scanlon, Joel Hernandez, and Laura Joyce. And of course, our media services team, who's recording this so that you can see this via video if you've missed any part of it. So after the panel, we'll have some light refreshments. We hope that you'll join us. And at this point, I'd like to hand over to Stephanie LaRue, who will introduce our panelists.
Good afternoon, and thank you, Caroline. Welcome, and thank you all for joining us today. I am Stephanie LaRue. I am the Associate Director at CSREA, the Center for the Study of Race and Ethnicity in America. CSREA is an interdisciplinary hub that aims to build community with the public and among scholars and students working on race and ethnicity in America. We at the center are very excited to continue our collaboration with the School of Public Health in what marks the final event in a four-part series on race and health equity. And we were just talking, Caroline and I, earlier, we're like, this worked out really well. We should do this again. So stay tuned for more. In this series, we have explored the social determinants of racial and ethnic disparities in health and health care, and we are excited to continue this conversation. Today, specifically, we welcome a distinguished group of panelists to close out the Building Health Equity in an Unequal World series, the World Series. Yeah. Our panelists are Dr. Gilbert G., Professor of Community Health Sciences at the Fielding School of Public Health at the University of California, Los Angeles. Also, Dr. Jazz Ahluwalia, Professor of Behavioral and Social Sciences and Professor of Medicine at Brown University, as well as Dr. Alana LeBron, Assistant Professor of Chicano and Latino Studies and Public Health at the University of California, Irvine. Please join me in welcoming our panelists. We'll actually start the panel discussion with Dr. G.
All right, good afternoon. You can all hear me, yes? Do I need this? All right. I'm really pleased to be here. Thank you so much for this invitation. You want me to mic up? All right, I'll mic up. Okay. And I'm going to talk today about racism and how it plays a role in health equity. And as we talk about racism, I'm going to be talking about it at multiple levels and also across the life course. Now, to take as our point of departure, one statistic of health equity, you know that we see that there are persistent inequities in health across time and across the life course for many health indicators. In this case, we're looking at years of life expectancy. So we can see that over time, from the 1950s onward, we've had a persistent inequality in health. And in 2010, there was about a 4-year gap in life expectancy between blacks and whites. So an infant born who is white could expect to live 4 years more than an infant who is black. We see that also in specific health indicators such as diabetes. And this gap that persists across many outcomes, diabetes being one other example, is something that has really been a vexing problem that we've been trying to grapple as a nation. And this has occurred as one of the goals in Healthy People 2020, which, as you know, is the nation's health planning document. One of the major goals of Healthy People 2020 is to reduce these inequalities in health. And according to Healthy People 2020, in order to do so, we have to pay attention to the historical and contemporary injustices that play a role in creating these health inequities. Now, when we think about that, we really need to think really what that really means. And according to Paul Braveman, equity means social justice. And if we're talking about social justice in the context of the United States, you have to talk about racism. And certainly many people have talked about racism and thought about it in many ways. I'm pointing out Carmichael and Hamilton, mainly because they were one of the first people to talk about racism at multiple levels. And thinking about this at multiple levels really needs to shape how we think and do our work. Certainly, we're not alone in this venture. Many scientific bodies have grappled with this, including the Surgeon General's Office, the National Academies of Science, the American Public Health Association, and the National Institute of Health, just to name a few agencies and some of the reports that they've published over the last decade and a half or so. Now, one thing that's been a marker of conversation is racial microaggressions, right? And so these are day-to-day incivilities. These are things with people appropriating your culture, or these microaggressions that happen when people make stereotypes and assumptions about you. And you can think of it this way, right? Each one is like a little peck by a chicken. And by itself, a little peck by a chicken isn't really going to do much to you. But you think about the accumulation of these little pecks over time. 1,000 pecks by 1,000 chickens over 10 years might be way more consequential. And let me give you a little quick video to show you how we might think about this by somebody who's...
Do I get stress headaches at work? Yes, definitely. From the moment I get in this, Denise, we need this, Denise, we need that, which is stressful, because my name is Linda. Denise is the other black woman that works here. By 10 a.m., someone in the copy room makes a joke about Kobe Bryant, and everyone looks at me to make sure it's okay. And I smile like it's okay, but really, my head and neck are starting to throb. Then I spend the rest of the afternoon training my interns and answering their questions like, yes, black people use shampoo. No, I don't know any good reggae clubs around here. Yes, Condoleezza Rice is very articulate. Why do you sound so surprised? And no, I can't tell you where to buy weed. And that's when I reach for the cedric. Cedric for racial tension ethics. Except our take on this fact. Taking me from oh no, you didn't to I wish him up.
Okay, so Queen Latifah can certainly talk about this way in a much better fashion than I can, that's for sure. But it really kind of draws upon this larger body of research on stress and how these microaggressions where people make assumptions about you on a day-to-day basis might be related to health, right? These chronic stressors lead to illness if they're not protected and mitigated by coping resources that we have. There's been a whole lot of research on this, not only here in the United States, but around the world. I'll give you one example from some work we did with Asian Americans, where we looked at a national sample. And here we have a whole bunch of different health problems, ranging from depressive disorder to respiratory problems like asthma and a global marker of self-rated health. We have light blue bars representing people who report very little discrimination, darker blue bars representing more reports of discrimination. And what you see across these health problems is a dose-response relationship between reports of discrimination and health problems, and this is controlling for poverty, education, region, and a whole bunch of other stuff. This study is just one of hundreds of studies. There's been probably about 6 meta-analyses that have all shown the same pattern, that more reports of discrimination are associated with greater morbidity. There's a few mortality-based studies on this topic as well. Now, this issue of microaggressions certainly has occupied a lot of our thinking and a lot of our space. It's certainly been a big issue at UCLA, but it's really only one piece of the puzzle. And we have to remember that we have to think about health ecologically. Health is not just a product of things that are happening at one level, and certainly Uri Bronfenbrenner and many others have espoused an ecological perspective. arguing that our health is not simply the product of our genetics and of our behavior and of our diets, but also of where we live, where we work, where we play, of the laws of the land, of the culture, and all those other things that shape our lives. And so this multi-level perspective of thinking about the production of health applies to thinking about racism just as well. And so microaggressions are really the tip of the iceberg. And certainly they are an important part, don't get me wrong, but beneath the surface of what we can easily see is the rest of the iceberg that is more intractable and more deadly and harder to change course, and I would argue more consequential for reversing the course of health inequalities than we are with just the actions at the tip of the iceberg. An example of this research comes from work on residential segregation. Certainly many studies have shown this. This is one example of how segregation looks on the ground. These are graphs of Detroit, Michigan. And the darker green means a higher percentage of African Americans. In 1990, 9 out of 10 whites or 9 out of 10 blacks would have to move across neighborhoods to integrate Detroit as a whole. That has not changed in the year 2010, even though we have slightly more precise graphs on this matter. Okay? And many people have written on this topic, Tom Levis, David Williams, myself, have really talked about the importance of segregation, but it's really only one marker. And as I talked to some other people about earlier, we really need to start thinking about other ways of thinking about structural racism. I'm happy to talk about that in the Q&A. But I'm going to shift gears a little bit and add another piece to this layer, which is thinking about all of this stuff across the life course. Certainly, we understand that humans don't just live in a particular moment in time, but we develop over the course of our lives. As we get older, we encounter new social institutions. And an important thing about the life course is the social aspect of it. The ages of 16, 18, 21, 60, 65, 100 are not only important because of their biological significance of growing older by a couple years, but because of their social significance that allows you entry into social institutions, your ability to vote, and things of that nature. And so when we think about the life course and we think about race, we have to couple them because our understanding in our lives that are racialized at very early ages. And I'll give you an example of research from Van Ostell and Fagan. So this is ethnographic work. They looked at children playing on playgrounds, and this is one of the quotes. No, you can't pull this wagon. Only white Americans pull this wagon. And this is Renee, who is 4, who talks to Ling Mai, who's 3. Give you another quote. It's Brittany, who's 3, saying to Talisha, who's 3, you're the same color as rabbit poop, see? Your skin is shitty. You have to leave. So children as young as 3 are using the same ideas and labels that we use as adults in order to segregate sandboxes. Now, one way we could maybe put a conceptual framework around this is to create a little graph that might look something like this. Kids are born, they go to school, they work, and hopefully retire, right? And in our lives, they're interrupted by things such as unemployment, underemployment, being thrown in jail, being sick, and all that. And those undesirable times, if you will, are shaded in blue here on this little graphic. What if your lives were interrupted by racism? It would probably look something more like this, where the blue bar is greatly expanded. And not only that, remember that 4-year gap in life expectancy? That's shown here. So what you have is a shorter life with greater strife as a result of racism. Certainly, racism is a waste of time in many ways, and the research is showing that. I'll give you a couple of examples. I won't belabor them for the sake of time, but consider one study where they looked at driver behavior and pedestrian crossing crosswalks. So this was a study where they had a black pedestrian and a white pedestrian standing at a crosswalk waiting to cross the street. And you needed a car to stop and yield for you to cross. And they looked at how long it took for a white pedestrian versus a black pedestrian to wait for a car to stop. And essentially what they found was that the black pedestrian spent 33% more time waiting for a car to stop just to let them cross the street. This is something that's so mundane, but all those little pecks add up over time. Other studies have talked about the same thing. For example, Doug Massey did a study on renting an apartment where they looked at black-sounding accents on the phone versus white-sounding accents. And what they found was that people who were trying to rent an apartment who had a black-sounding accent spent twice as long to try to get an apartment. And this was happening because the people who owned the apartments on the phone were less willing to answer messages and callbacks and things like that. So again, this is another example. And I won't go through the rest of these, but there's a whole literature looking at waiting times for kidney transplants, sitting at ER departments, and also disparities in time in prison for similar offenses. Now, I'm going to switch gears and look at time in a different way, using data from the National Longitudinal Surveys of Mature and Young Women. This is a nationally representative sample of 10,000 working women in the US that began in the 60s. What's significant about this data set is, to my knowledge, it's the longest running data set that asks a large sample of representative working people about their experiences of discrimination prospectively. Okay? And so you might ask yourself, what do patterns of discrimination look like as people get older? In this case, working women. Okay? First, we're going to look at white women. And we're going to actually look at the question of age discrimination, which is what this graph is, this blue line. Okay? And so what you see here, this is asking about age discrimination, is that when women are young, they report relatively high levels of age discrimination. It drops as they get older, in their 30s, and it rises again as they get into their 50s and 60s. This is kind of what we would expect based on research on discrimination. When you're young, people might discriminate against you because you don't have enough experience and those kinds of things related to your age. This rises as you get into their 60s, but it drops again later in life. And I think this drop has two parts to it. One has to do with a little more gravitas and power as you move higher into, later into your career. But the other part is if you work in a very toxic environment, you might just say, forget it, I'm gonna retire. Okay. So you see this age-related pattern on reports of age discrimination. Now, sexism, which is the green line, shows a different pattern. At the very ages when women are reporting the least age discrimination, they're reporting the most sexism, right? So this is really important in thinking about the intersectionality component of discrimination, that we can't just think about one dimension of discrimination over time. And it's not just either or, it changes dynamically with age. And this is, the red line is race discrimination, and not surprisingly, white women don't report a lot of race discrimination. If we were to look at African American women, you see that reports of race discrimination are much higher, as you would expect. But also noteworthy here is that the patterns for black women looking at age and gender discrimination are relatively the same as that of white women. The amplitudes are a little different, the shape, the pattern is the same. And so this gives us fuel for thought in terms of building coalitions and finding common ground as well. Now, we can look at all these and think about this in consideration of what's going on nationally with all this stuff going on with like Black Lives Matter, and things like that. And you think about children like Tamir Rice, who were killed at a very young age. And this nice kind of theoretical model that we have here really needs to be redrawn to account for that, to look something more like this, right? And so we really need to think about discrimination, racism across ages, across time, because the nature of our society and the social institutions that we bump into change with age. Now, thus far I've presented a fairly oppressive view of all of this, which is definitely part of what's the reality, but also we need to acknowledge the resilience that's common in our communities. Let me just give you a quick quote from some work we did with some focus groups. This is a woman in Arkansas, and she said, I was in a car accident and I needed prescriptions filled. I dropped over to the city welfare office and this woman treated me like I was scamming something from her. And I'm also on depression medication. I said, well, look, let's forget about the painkillers if this is how you're going to be. Just give me my depression medication. Yeah, it would be great to have it because I'm in pain. That's why it was just prescribed to me. But if you're going to make a bigger deal about it, then see ya. And what this says is that people are willing to forgo medications. They're willing to endure pain in order to maintain their dignity and self-respect. And this is the tradition that we need to recognize in terms of resilience in our communities, in terms of the social movements, in terms of the institutions that we develop in order to advocate for the work of our communities, and resulting in some of the policies that might also be protective. And so let me give you some work by Doug Almond. This is kind of a busy slide, so let me walk you through it. We got calendar year over here, like 1974. Okay. We also have on the y-axis the post-neonatal infant mortality rate. So as you go higher up on the y-axis, more babies are dying. This cluster down here represents the line for white babies. So not surprisingly, with improvements in public health, you see the white neonatal infant mortality rate dropping over time. Okay, but now consider this green line, which is Illinois, black babies in Illinois. There's a disparity. That disparity has been widening up to starting from 1946, and it dropped after 1965. Okay. Let's take a look at Mississippi, a much greater disparity to begin with that widens hugely over that period, but again, drops the most precipitously after 1965. And I would encourage you to read Doug Allman's paper because it's really carefully done. He looked at a lot of alternative counterfactuals and things like that. His main conclusion was that this is an effect of the Civil Rights Act of the 1960s, right? With the desegregation of hospitals and things of that nature. So essentially, the places with the greatest disparity also had the greatest decrease in disparity as a result of national policy in that case. Okay. So just to kind of close this up, I talked about racism. We need to think about it as a public health issue as much as it is a civil rights and moral and political issue. We need to think about it from a multiple level perspective. We need to think about this across the life course and in an intersectionality lens as well. And we also need to recognize and think about the resilience in our communities. So with that, I want to thank you for your time and participation.
Okay, got 20 minutes, so I will tell you about some of my work, but put in the context again of sort of health equity, which I believe is both a medical and a moral imperative, and then sort of link it to some of the work and recent work that we just did with African Americans and smoking. So the first question I want to sort of pose is, to achieve health equity, does race, ethnicity matter? I'm looking for audience participation here. For those that are not. So how many, there's no right answer, by the way. This is one of those, there's no right answer. You could say yes, you could say no. And it's not meant to be a trick question, although it sounds like a trick question. So does race, ethnicity matter with regards to health equity? Raise your hand if you believe yes. Okay, so that's for almost everyone. Okay, good. Okay, so I'm going to start with this slide, which is data that we're, I'll tell you about the study a little bit later, but I want to just sort of give you sort of backwards, actually give you the findings right away, which is that if we look at a group of African Americans and a group of whites, and this is my area of research for the last 25 years, and we intervene on them with state-of-the-art medication, counseling to get them to quit smoking, and we stratify on a couple of the things that you need to. And at the end of 6 months, you see what the quit rates are. What you find is that the quit rates are right here. The overall quit rates in African Americans is 16%, and then for whites, it's 38%. So back to my first question on the previous slide, does race matter? Okay. Then you can, and just since I have this particular slide, what we did is we broke it by tertile of medication level. Varenicline is Chantix. People took the medication, both African Americans and whites. And the levels for African Americans in terms of the actual medication level was a little bit lower for each tertile, if it makes sense. So tertile just means we divide those with the lowest level of medication in their blood was first tertile. Usually it's related not to metabolism, but to adherence to the medication. The second tertile, and the third tertile. What you see is a nice dose response curve. The more you take the medicine, the stronger the effect, right? The higher the quit rate. BLQ stands for below quantifiable level. And interestingly enough, very striking difference, right? For African Americans, if they essentially have no medication on board, at least at week 4 when we drew the blood, their quit rates at 6 months are 4% compared to 28%. There's always these interesting findings. Like if you take the lowest quartile for whites, their quit rate is higher than the highest tertile for blacks. You follow? Right, so that's sort of interesting, okay. So I suspect many of the speakers are gonna have similar slides, but when I went to med school, which is a while ago, 30 years or something like that, then when we used to talk about determinants of health, the slide would look very different. It just did, and I think we've come a long way in understanding what determines health. It's sort of health services, biology, individual behavior, social environment, and physical environment. And race, ethnicity, sort of, if you will, I didn't know where to put it, so I sort of put it in biology and genetics. Of course, it has an impact on sort of all these areas, but it's sort of in there. And then just to have a definition of social determinants, because we're all going to be throwing that term around, it's social determinants of health are conditions in which people are born, grow, live, work, and age. These circumstances are shaped by the distribution of money, power, and resources at the global, national, and local levels. The social determinants of health are mostly responsible for health inequities, the unfair and avoidable differences in health status. So one thing that's interesting sort of right away is that race itself is not, by itself, is not a social determinant of health, right? Okay, so I was having fun with this last couple of days and was on the phone just coincidentally for some other reason with a Yale economist, a health economist this morning, and I was talking to her about this. So I was sort of intrigued by this. So if you take the 4 members of the Walton family, their siblings, this is the Walmart family, and then add their wealth, not income, but wealth, with Bill Gates, who's now number 2, right? No longer number 1, because Jeff Bezos is number 1. Their wealth comes to $250 billion. If you take the bottom 40% of Americans with wealth, they also have $250 billion. How much is the bottom 40% of Americans? How many millions of people is that? I asked a student who was in my office yesterday. She got it right, exactly to the T. Wild guess. 120 million? That's a little high. Yeah, that would be high. So I think it's either 40 or 50. Let me just check. I don't have that. It's 40 million Americans. So 40 million Americans have the same wealth as 5 people. That's just, I know we all know this, but every time I see that number, it's just staggering. If I had Bill Gates right here, and then the 4 Waltons, I would need 40 million Americans to have the same wealth. And that's just really incredibly an interesting way to think about it. So I got more interested in this last night and yesterday, so I started poking in a little bit more about sort of wealth and income, and you'll see why as I bring it back to the smoking story. So you can also see in here, and this is again wealth, right? And so you can look at wealth in lower, oh, come on, Jess, in sort of lower income groups, however it's defined, and in middle income. And you can see here that, interestingly enough, from 2007 to 2013, for whites, there was actually wow, that's really interesting. There was a dramatic decline in wealth, but then a rise again, and the gap between whites and African Americans is about 4-fold. But in middle income, it's quite striking. It's 150,000 and 40,000. Again, it's also about 4-fold, right? This was my favorite slide. And it got me thinking about our findings, which is that there's a big difference, as you may or may not know, between income and wealth, right? So income and wealth are 2 very, very different things. And part of it is that if we, so this is wealth, right? And if you look at income, so this is a 4-fold disparity in wealth. If you look at disparities in income, which I don't have, it would not be 4-fold, it would be significantly smaller. If you take the US income disparity and you take top 1% of households, their total income in every given year is about $1.6 trillion in the US. If you take the bottom 40% of households in the US, their total income is also about the same, about $1.58 trillion. I didn't actually look up how many people top 1% is, but as you can imagine, it's going to be a pretty small number. But if you look at wealth disparities in the same group of people, the top 1% of households with regards to wealth and the bottom 40% of households with regards to wealth, which remember we said was 250 billion, is the same as 5 people. The wealth disparity is 130-fold difference, right? It's 250 billion versus a staggering $34.7 trillion in wealth of the top 1%. So I don't know if this is new information to you. I know you all knew this conceptually, but when you start putting numbers to it, like 5 people and 100,000 people and things like that, you begin to understand. And I think this is important to understand what income is and what wealth is and what it means. You can only accumulate wealth, right? So new generation immigrants, let's say like my family, is going to have less wealth. We will do better on income, let's say, because my dad's an academic, but on wealth, it'll be different. If you're 5th generation white in this country, I suspect that your wealth might be higher. If you're African American, your income might be pretty good, but your wealth is going to be very small compared to other populations. And we'll come back to why that's important, even in tobacco research. So how, we have to sort of define health equity too. So I like this definition. Health equity, it's from CDC, is achieved when every person has the opportunity to attain his or her full health potential, and no one is disadvantaged from achieving this potential because of social position or other socially determined circumstances. And then I found this little diagram that showed it best. I thought this was good, a nice pictorial way to explain it. So here's equality. Everyone has the same size stool, but everyone is afforded different opportunities by virtue of history, racism, whatever the case might be. And this is what equity is about, right? It's when everyone has the opportunity to attain his or her full health potential. So the potential to reach the apple is the same here, but it's by sort of a larger stepping stool, if you will. And this is what sort of equity is about. So this is a graph that shows the prevalence of smoking in this country, which has fallen pretty dramatically since 1965, down to these numbers here in 1992. That's when I started my first academic job. And these all four groups have continued to decline, such that African Americans and whites have about the same prevalence of smoking. And it's significantly lower than it was then. It's down to, well, it depends what numbers you look at, but let's say somewhere between 16, 18%. But smoking has continued to decline in general, but for all groups, but not equally. And this is looking not by race, but by educational level. So those with some high school level, from 1966 to 2015, there's been a 40% decline in prevalence, high school degree 52%, 61% with some college, and a very striking decline in college degree graduates with an 83% decline in smoking. So as many of us know, and people in the audience do work in this area, smoking is now relegated to people largely of ethnic minorities, lower socioeconomic status, those with dual addictions, and those who have significant mental health disorders. So just very briefly about African American smokers, they smoke less number of cigarettes per day. So these are going to be little tidbits you have to remember. They smoke less number of cigarettes per day, let's say on average 13 cigarettes per day versus 18 cigarettes a day for whites. And this is my area of research, so it's not to ignore other groups. Latinos are at 11 cigarettes a day, and Asian Americans are 12 cigarettes a day. So they smoke less number of cigarettes a day. They start smoking later in life, so by an order of 1 to 2 years later. So white kids start, let's say on average at 13, 14 years old on average, and then African Americans are about 2 years later. The mean age of initiation in this country in general is moving towards a later age, which is very interesting because there's some other things around like e-cigarettes and so on and so forth. The levels of smoking by ethnicity are strikingly different. A pack a day, which is hard to do in today's world. Whites are most represented in that group. They're most likely to smoke heavier. And then African Americans, 25% smoke a pack a day or more. And then if you go down to light smoking, 1 to 10 cigarettes a day, African Americans are 43% versus whites at, let's say, 25%. And then if you get to intermittent or non-daily smokers, once again, African Americans are more likely to be non-daily smokers than are whites. So, right, you're getting the picture. African Americans start smoking later. They smoke less number of cigarettes, quite a bit. And they also, that's shown this way too, why it's less, because they smoke non-daily more commonly, and they smoke fewer number of cigarettes, of course. Now, nicotine is what's in cigarettes, and you can measure nicotine in the blood. It's got a short half-life, but this paper was done about 20 years ago by Eliseo Perez-Estable, who some of you know is the director of NIMHD now, but back then he was at UCSF. Him and Neil Benowitz and others did this paper showing nicotine intake per cigarette. So adjusting per cigarette was significantly higher in African Americans than they were in Caucasians, 1.41 milligrams, and then 1.10 milligrams. Interesting enough, Chinese Americans in the Bay Area were significantly lower at 0.73. But so higher nicotine levels in African Americans than Caucasians. So people began to think back then, well, this might have ramifications. And the higher in nicotine was because there was slower clearance of cotinine. That's the first breakdown product of nicotine. It's metabolized to cotinine. And second was actual greater intake of nicotine per unit cigarette. Well, people began to think, well, if they take more nicotine in per cigarette, what else might they take in more of per cigarette? CO2, yep, absolutely. Carbon monoxide, what else? Tar, which is sort of a generic term for bad things, which includes lots of carcinogens and toxicants and other things like that. So people began to think about that. And of course, it may result in higher rates of lung cancer. And as you may or may not know, African Americans do have significantly higher rates of lung cancer prevalence, both prevalence and incidence. Don't worry about mortality, because that's true too, because mortality has other health determinants like access to care, insurance, access to sort of state-of-the-art medical facilities. So take out mortality and just look at incidence and prevalence. And so you can see it's quite striking, actually. And here's the interesting part, is that for men who smoke 10 cigarettes a day versus men who smoke a pack and a half, this is a little bit older data, but pack and a half a day. The difference at pack and a half a day is very little. The rate of lung cancer per 100,000 population for African Americans, which is this top line, and whites, which is this light blue line, is about the same. You follow? Right? So it's about the same if you're a heavy smoker. But if you're more of a light smoker, which remember African Americans are more likely to be light smokers, then your rate of lung cancer is strikingly different, right? It is over here for whites, at age 80, it's about 1,000 per 100,000 population. And for African Americans, it's almost double. I mean, double's a big number. It's 2,000 for every 100,000 with regards to, again, the rate of lung cancer. And you may wonder, well, that's sort of a little bit odd. Why should it be any different, right? Why should it be different that the rate of lung cancer should be different for whites and blacks at 30 cigarettes a day versus 10 cigarettes a day? Anyone have an idea? Social, maybe inhale more, okay, yeah.
Other health factors?
Yeah, other health factors. Well, so it turns out that Neil Benowitz, the guy at San Francisco again, and then we've got some more fresh data, but I didn't want to show you redundant data that's going to come out, that shows that this is very interesting to me. So if you're a heavier smoker versus a light smoker, blacks are in triangle, whites are in squares. At the heavier levels of smoking, whites and blacks have the same level, I forgot to tell you, 1-hydroxypyrene. That's a very potent carcinogen. It's what's called a polycyclic aromatic hydrocarbon. And again, it's very important to adjust per unit cigarette, right? So this is per cigarette. So at the higher level of smoking, this particular carcinogen has the same levels in whites and blacks. So not that you can really compare the data, at the higher level of smoking, the lung cancer rates are about the same, right? I mean, this is a little bit of a stretch, but you have to take data and continue to try to interpret it. And at the lower levels of smoking down here, 0 to 9 cigarettes a day, African Americans have 3 times the level of hydroxypyrene compared to whites. This is unbelievable per unit cigarette. Obviously, right, this number is much higher than this, but it's adjusted per unit cigarette. So that may begin to tell the story, oh wait, if Africans are more likely to be light smokers, and if you start to manipulate the data, you begin to see that in fact, even that at lighter smoker levels, that might begin to explain some of this. Now, obviously, we can talk more about this, and we can conclude that this really doesn't fully explain it, and I don't think it does, but it begins to tell a little bit more of the story. So we decided so I've been doing this work in this area for about 25 years, that we really need to do this study, which we started, I think, about 4 years ago, which is enroll African Americans and whites. We had done tons of work in African Americans. Others had done works in mixed populations. And when we analyzed our data, our quit rates in African American, 4 or 5 different clinical trials, was always significantly lower than other populations. And when you did secondary analysis of large mixed trials, like let's say funded by the pharmaceutical industry or colleagues around the country who did trials enrolling sort of general population, and you analyze the data in a secondary way, sort of post hoc analyses, people would find that African Americans have lower quit rates. So it was all pretty consistent. But there are lots of issues, confounding, bias, so on and so forth. So we said, let's do what we believe is the strongest design possible. You enroll African Americans, you enroll whites, you give them state-of-the-art smoking cessation, let's say varenicline and guideline-based smoking cessation. And then we stratified on age, enrolled an equal number of people less than age 40 and greater than 40, because that age is related to the outcome, which is cessation, and then male and female. Now, there are many other factors you can stratify on that are related to outcome, menthol, SES, and so on and so forth, but you can't, of course, overly stratify, otherwise your cells will become absolutely tiny and it becomes impossible to recruit. So you choose what you think are important stratification variables. So that's the design, 224 in each arm, and then you follow them. Our aim, of course, was the very simple question is to describe the quit rates between African Americans and whites at 6 months. To me, the more interesting aim was a secondary aim, which is to identify the smoking, psychosocial, treatment process, and biological factors that explain the relationship between race, ethnicity, and abstinence, which is these right here, these characteristics: nicotine dependence, nicotine intake, socioeconomic status, social support, negative affect, stress, racism, treatment process factors, side effects of the medication, adherence, withdrawal, craving, and biological factors such as nicotine metabolism phenotype, which is 3-hydroxycotinine over cotinine. In other words, cotinine is then metabolized further and is hydroxylated, or the nicotine metabolism genotype. We didn't talk all about genetics, but CYP2A6 is the enzyme that metabolizes nicotine. And interestingly enough, Rachel Tyndale and her group and others, with some of our samples and studies over the last 10, 15 years, have looked at 2A6 in African Americans, and African Americans do have a allele frequency that's different, that in fact does show a greater percentage of what are called slower metabolizers and intermediate metabolizers of CYP2A6 compared to whites, okay? So that's potentially important. And then as an aside, we had some interest in telomere, which is related to chromosomes, skin color, because we were interested in racism, hair cortisol, stress, and carcinogens, of course, NNAL1-hop and volatile organic compounds. So we were interested in sort of what might be mediators of this and moderators. And as I showed you earlier, the first slide of the talk, very simply, quit rates were 14% versus 31% at week 4. African Americans had a lower quit rate than whites, and at week 12 was 18% versus 31, and at week 26, 14% versus 24%. So does race matter? Yes. Not so fast. There was a trick, and I'm almost done, actually. Because there's very little time left, and I think I only have 2-3 more slides, is that if you do logistic regression, which you need to do adjust, so first, and I'm not very strong quantitatively, so this is done by the chair of biostatistics at Kansas, by Matt Mayo, who's been there for about 20, 25 years. I recruited him 20 years ago. If you put into the model the stratification factors, age and sex, the two things that come out are, of course, race, 0.51 odds ratio, and age, 0.6 odds ratio. So you say, well, it is race. Race is still there. And actually, I gave a talk to the postdocs here a couple months ago presenting these findings as race matters. Race did matter. Race was a predictor. You're not going to believe this. We submitted the paper to JAMA, got turned down, thank God. Rarely will you ever say that. And then for some reason, I don't know why, but Nikki, my colleague at Kansas, and Matt started to sort of think about this some more and Matt said, we're not doing this right. We need to do this in a different way to look at the data. Again, I'm not very strong quantitatively, but he did what's called a best subset logistic regression modeling of the best 2, 3, 4, 5, 6 factor models jointly predicting week 26 abstinence. And very interestingly enough, came with a very different finding. Race completely falls out. It is no longer predictive of abstinence. And what is predictive of abstinence in hierarchy with the highest odds ratio is home ownership at 2.91, adherence to study sessions, which really is probably a marker for counseling sessions, at 2.88 odds ratio. Income per household per $1,000 household was 1.03 odds ratio. Cotinine, which is that biomarker of nicotine, was 0.997. And neighborhood problems, sort of a measure of neighborhood problems, was 0.89, which of course means the higher the neighborhood problems, the lower the quit rate. So that's why it's less than 1. And perceived stress using the perceived stress scale was 0.91. And so we've obviously, we didn't need to retract the article because it never got accepted. We are now going to resubmit it with this. And obviously I jumped over lots of sort of other models and logistic regression models and looking at Rennicklin levels and so on and so forth. But so where we are, some of you may have seen this. It's a great article by Steve Thomas in American Journal of Public Health, looking at sort of health disparities, first generation research, which is just basically saying there's a disparities, which is at this point ho-hum. Second generation, which is explaining reasons for disparities. Often we get stuck here with diabetes and so on and so forth. So we feel like we're beginning to come out of this in tobacco now as we begin to understand it. But the third generation is a tough one. It's providing solutions for eliminating health disparities, right? How are we going to provide solutions, so to speak? This is a bit rhetorical for about home ownership, which is wealth. That's why I showed you all those wealth slides, right? Income, those were those income slides. This you could do something about. Adherence. Cotinine, you possibly could do things about. Some people in the audience, Jen Tidy does work on very low nicotine cigarettes. You could begin to address that. Neighborhood problems, green spaces, things of that nature, and perceived stress. Well, you saw Gil's very, very funny, but not funny, Excedrin ad. So anyway, I just always have to thank my colleagues, and I was adding more names to the list that have been, I'm getting old. This is all a sign of. I have to thank someone else. Today is my 25th anniversary, turns out, and so I have to thank my wife. And of course, she'll be pissed that I show this slide. She always is whenever I do it. I love this. It's my favorite picture of her. So after this, I'm taking a train back to Jersey, where my family is, because my kids are in high school, ready to go to college. And so I will do that. So thank you all for coming today, and thanks for all the work you do every day.
All right. Well, good afternoon. Thank you to the School of Public Health and the Center for the Study of Race and Ethnicity in America for the opportunity to join this important discussion today. In focusing on building health equity in an unequal world, I'm going to talk a bit about how structural racism shapes the health and well-being of Latino communities, and I'll focus specifically on our protracted period of restrictive immigration-related policies as an example of structural racism. And then I'll close by really pointing to important and promising opportunities for intervention for the field of public health in an effort to mitigate the social contexts that contribute to health inequities. So, U.S. immigration policies have long been racialized. And in the case of Latinos, in discourse and in practice, Latinos are often characterized as perpetual foreigners whose citizenship status is suspect, if not assumed to be unauthorized. And in the 21st century, according to the Department of Homeland Security, from 2000 to 2015, there were more deportations than in the 20th century in its entirety. And this increase in deportations from the United States really coincides with an increase in interior immigration-related enforcement, as well as enhanced collaborations between federal immigration enforcement agencies and local law enforcement. In addition to bringing immigration authorities closer to day-to-day life for Latinos, interior immigrant policing operations are salient to Latinos, as immigrants from Latin America constitute about 96% of deportations since 2010. And while technically these policies focus on undocumented immigrants, evidence suggests that for Latinos, the effects are felt for U.S.-born Latinos and for immigrant Latinos, both those who are undocumented and who may have more protected immigration-related statuses. So, for example, after Arizona lawmakers passed a law mandating that local police inquire about immigration statuses during routine traffic stops, this is SB 1070, there was a 2010 survey of Latino voters, and the survey found that 72% believed that the police were primarily targeting Latinos in implementing this policy. And a later survey found that the majority of Latinos believed that their group was absorbing the brunt of these restrictive immigration-related policies. So Latinos in Arizona thought SB 1070 was about them, and people are very sensitive to these state and federal immigration policy contexts. And for some Latinos, deportation is not an abstraction. It's a reality that can bring concerns for families, for friends, for coworkers, and students within and across Latino communities. In 2015, an estimated 61% of Latinos reported knowing someone who is undocumented, and 36% reported knowing someone who had been detained or deported. And recent research has really documented a decline in healthcare utilization and use of public health services following the implementation of restrictive state-level immigration-related policies. And these patterns signal a corrosion in trust towards public institutions. These vigilant responses to this shifting context are also seen in demonstrated declines in healthcare utilization and safety net program utilization following the change in presidential administrations. And the consequences of these policies can reverberate through communities through mechanisms including racial profiling and also social networks. So this context affects not only undocumented immigrants, but also spills over to affect US-born Latinos, naturalized citizens, and non-citizen immigrants. And individuals, families, and communities are making very careful assessments of this shifting immigration context. So I worked for several years in Detroit with the Healthy Environments Partnership, which is a community-based participatory research partnership. And in our qualitative research with Latinas in Detroit, we asked them about immigration-related policies and other social and economic features of their day-to-day lives in Detroit. And this work really shed light on how immigrants, mixed-status families, and immigrant communities more generally were really navigating this threat of deportation for themselves and for loved ones. Additionally, and importantly, this work shed light on the implications of this context for social and economic outcomes that are also linked with health. So Detroit's a little bit unique in that it has experienced a longstanding presence of border enforcement agencies in Detroit because of the proximity to Canada. And like many other cities and towns across the country, Detroit has also been affected by an increasing presence of immigration enforcement through both the creation of interior immigration enforcement agencies and also enhanced collaboration and sharing of resources between federal immigration enforcement agencies and local law enforcement. And so in our interviews with Mexican immigrant women and US-born Mexican origin women, women talked about how multiple social agents representing a range of institutions leverage several racializing markers in attempts to assess their immigration status and therefore access to the resources over which those social agents had power. As these examples indicate, these racializing markers that were leveraged in these processes included having an expired or no state ID or driver's license, speaking Spanish or having a Spanish accent, being born outside of the United States, having an ethnic name, and living in Southwest Detroit because of ways in which race-based residential segregation operate. And then also physical features were invoked in these processes. So each of these symbols were linked with women's reports of heightened scrutiny of their immigration-related status. And this emphasis on immigration status was not restricted to the experiences of immigrant women in this sample. US-born women also reported this heightened scrutiny. And for them, as this quote really illustrates, there was this challenge towards their entitlement to these citizenship-related privileges. And they were often burdened with proving their citizenship and also navigating and affirming identity in this highly stigmatizing context. Several women described these processes and experiences as clipping their wings or making them feel like caged birds. And this analogy really speaks to their experiences with multiple systems of blocked opportunities by virtue of their social location and the multiple symbols that continue to be used in these processes. And these references really signal the enduring health impacts of these immigration policies. That is, that there could be psychosocial and physical impacts that can accumulate over time and that can be injurious to the body over the life course. In bringing together women's accounts in this work, they really highlighted the interconnected and the dynamic nature of their experiences with structural racism through these immigration policies that were unfolding and becoming increasingly entangled. And these were often linked with institutions that are broadly charged with promoting the public's well-being. For example, immigration officials enacted their power over surveillance of residents and over immigration-related detention and deportation. So immigration officials often surveilled residents within and at the boundaries of their neighborhood that has often been known as an ethnic enclave in the area. Likewise, police exercise their authority over driver's licenses and contact with immigration officials. This form of surveillance often happened when driving and when conducting activities related to caregiving and employment-related responsibilities. These practices were linked with enhanced collaborations between federal and local law enforcement agencies under the program that is now called Secure Communities. And in Michigan, the Secretary of State's office issues and renews state IDs and driver's licenses. And in 2008, the state of Michigan began denying licenses to residents who could not prove their authorized U.S. presence. This state response was in direct response to the 2005 Real ID Act that mandated that in order for state IDs or driver's licenses to be accepted for the purposes of federal identification, states needed to then carry the burden of ensuring that they had issued those IDs to individuals who could prove their authorized U.S. presence. And so at Secretary of State's offices, the clerks use their discretion in assessing immigration status and in issuing these driver's licenses and state IDs. Importantly, these IDs are needed for a host of factors in day-to-day life, including the need to vote and to access a host of health-related resources for oneself and for one's family. And social welfare caseworkers exercise their authority in scrutinizing eligibility for nutritional and medical assistance for women and their children. And these practices were born out of past welfare policies that required proof of identity and citizenship in accessing Medicaid. Also, during the time of this work, we saw the unfolding of the 2010 Patient Protection and Affordable Care Act. And this act certainly expanded access to health insurance for many, and it also restricted access to health insurance for several immigrant subgroups. And employers really exploited these vulnerabilities in their efforts to justify discriminatory treatment, including wage theft and exploitive work conditions. So they leveraged federal surveillance of their hiring practices as a justification for their exploitation of workers with more vulnerable immigration-related statuses. And so each of these is an example of an interaction that is happening at the interface of a legal institution. And some of these institutions, like thinking about the social welfare caseworkers, are often housed within departments of public health, and others are institutions that public health may interface with. And the driver's license really was a central symbol that these institutional agents were engaging in assessing women's access to the resources over which they held power. And the constant need to navigate within this interconnected system created a space that not only contributed to psychosocial stressors, but also has profound social and economic implications that are intricately linked with health. And I want to just pause and really sit with the profound role of ID-related policies that have emerged from restrictive immigration policy contexts. Government-issued IDs are increasingly needed to access healthcare-related resources, to engage with social welfare institutions, and to access financial resources. And the experiences of the Latino immigrant community in Flint at the height of media attention to the water crisis really remind us of this. So as one woman explained, I got close to see what they were giving out, and it was water. And the first thing they asked me for was my license. And so here was her encounter at a water distribution center, right? These were often at firehouses and churches, and there were several reports of signs that said state ID required in order to access clean, potable water in the context of lead-poisoned water. So as we zoom out from Detroit to Michigan to more national level patterns, some of my colleagues' recent scholarship involving a national sample of Latinos found that Latinos who live in locales where immigrant policing is most intense express lower levels of trust in the government as a source of health-related information. And we didn't see this pattern for other racial and ethnic groups in this national sample. And so this finding really points to policy feedback, that the nation's deployment of immigration policing conveys more widespread lessons to Latinos about the trustworthiness of public institutions. And as my colleagues on the panel mentioned, there is a growing literature that really links chronic activation of the stress response system to accelerated aging. And this growing literature can really teach us about the life course implications of this context for the health of Latinos. an accumulating body of evidence is really beginning to document the health impacts of this protracted period of restrictive immigration policies. Some work is showing that enhanced cardiovascular risk is linked with pathways, including deportation-related worries, as well as increases in institutional forms of discrimination that restrict access to healthcare, to employment opportunities, and to housing. Additionally, a recent study documented adverse birth outcomes for immigrant and U.S.-born Latina women following a large-scale workplace immigration raid. And other work has linked poorer mental health with living in a county with high levels of deportations. And yet other work has shown declines in self-rated health amongst immigrant and U.S.-born Latinos following a community immigration raid. And other scholarship has recently linked concerns about racial profiling from police with poorer self-rated health amongst U.S.-born and immigrant Latinos. And so in our work, and particularly in this moment in time, a question that many communities, local governments, and public health institutions are asking is how to promote the health and well-being of immigrant and racial minority communities in the context of heightened immigration enforcement and anti-immigrant, and by extension, anti-Latino sentiments and ideologies. So what can we do? In public health, our charge is to focus on factors that shape individual, family, and community health and well-being, and to intervene on those contexts in which people are living, learning, working, and playing to promote their health. And there's also an important role for ensuring access to safety net and healthcare-related resources as we work to ameliorate the health consequences of this unequal world. So what can that look like? I would first argue that we need to authentically value community knowledge, that we should partner with communities who hold deep and intimate knowledge of these issues and of community-related strengths. And community members have important insights into the appropriate solutions that are needed to move towards health equity. So creating opportunities for co-ownership of that assessment and intervention process with communities is important for enhancing the likelihood of effective and sustainable public health action. We also need to work to address the social and the physical conditions that undermine health. So a public health approach to building health equity really involves addressing these contexts, and the solutions to these challenges of our time are often found when we work with multiple actors, so outside of public health. And coalition building models really offer promise towards that end. So for example, a place-based approach to mitigating the consequences of exclusionary contexts would involve acting on our multiple levels of influence. This could include, for example, state, county, or city level action to create more inclusive contexts. So this might involve educating state and local policymakers about the health impacts, for example, of restrictive state ID policies. And it might mean stepping up when state and local jurisdictions are considering decisions that would undermine the public's health. In this moment, when the policy context seems very top-down, it's important to remember the value of these bottom-up approaches. That local communities have the power to develop the policies that can really reflect our values of inclusion and community trust. So as just one example, several Michigan communities have recently implemented local government-issued ID policies in an attempt to really enhance access to health-promoting resources. And this is part of a broader national social movement centered around economic and racial justice. And in Michigan, local health departments have been key allies in this work. We also need to work on strengthening trust towards public health institutions. This might involve looking inward to reflect on the ways in which our own institutions produce and reproduce health inequities. And this may surface a need to really strengthen organizational capacity to pursue these inquiries about our contributions to these inequities. And it also might surface a need to reflect on our capacity to engage authentically with communities. And there are important examples of organizational level interventions, like undoing racism interventions, that can teach us how to move towards health equity. And the community-based participatory research literature also teaches us how we can engage in more collaborative models with communities. We also need to ensure that our institutions reflect our constituents, the communities that public health institutions are intending to serve. And giving evidence that restrictive immigration policies are undermining trust in public health institutions, we need to develop practices to ensure that governmental agencies and healthcare providers are not seen as collaborating with police or immigration-related authorities. So this might involve a messaging campaign to really communicate this commitment and how that shows up in our practices. It might also involve incorporating community health worker and promotora models that have been shown to be effective at certainly delivering popular education and also bridging institutional gaps between individuals and communities and healthcare systems and public health institutions. So community health workers are members of affected communities, and given their positionality, they are more likely to be trusted by the residents that are served by our institutions. So community health workers may be able to provide assurances regarding the practices of public health institutions for the communities that they serve. And community health workers may also feed back community concerns to in turn shape our institutional behaviors. So in closing, we certainly have much work to do, and we must listen. And there are many promising models that we can look to as we really work to promote health equity. Thank you.